Good morning, Dr. Sammaritano.
Hi.
Yep, there you go.
So nice to meet you sort of in person.
Nice to meet you. Thanks for joining us today. How are you?
I'm good, thanks.
Wonderful.
Looking forward to updating people on lupus. I
Yeah, no,
thought,
this will be fantastic.
yeah, I thought it would be better. Initially we had discussed maybe antiphospholipid and
Yeah,
reproductive health, but I think this is a more generally, needed topic. So,
absolutely.
yeah.
Yeah. I mean, these updated guidelines for topics, conditions that run the gamut of impacts everybody is really important for us. So it was a perfect pivot. I appreciate it. Thank you.
Oh, of course. And you'll see, well, I don't know if you looked at the slides. I did send them in ahead of time, but
Yeah.
I'm going to review lupus briefly, talk about some important comorbidities that we sometimes don't pay enough attention to, and
Yep.
then present the guidelines. And hopefully, even though I have details on the slides, because I did, adjust slides from talks I give to rheumatology colleagues,
Hmm.
I think will be able to just bring home the main points that I think are useful to internists.
Yeah, no, I appreciate it. Thank you.
Yeah.
I think that Vivian should be online at some point to introduce you.
Okay.
Kirsten, did I know that I know you were emailing back and forth. Kirsten, do you know if there was an email correspondence making sure that Vivian would be here this morning?
I don't
I mean, it's still
recall.
early. She still has time to sign on.
Yeah, I don't recall. I'm
Okay.
sorry.
All right. All right. So, um, wonderful. So what I will do is I'm gonna share some slides, just kind of introduction slides, CME
Oh,
code, things like
oh,
that, and then we'll
oh,
probably get started a minute or two or a couple minutes after the hour, if that's okay.
oh, yeah, of course. So I should stop sharing mine now.
Yeah, I'll share the ones I have. I'm gonna mute everybody, but um, let's see here. You should be able to unmute yourself right now. There you go. And then also in case something goes on, you're also co-host, just in case.
Okay.
You never know.
You never know. Ah. I realize since since this picture was taken, we now a whole new hospital building like
You,
over the FDR.
there
Um
is. I was driving
next
over there a few weeks ago. It's incredible.
Yeah, it's next to this one.
Right.
It went up pretty quickly. It's obviously all orthopedics,
Hmm.
with a focus, I mean, primarily, inpatient spine and joint replacement. But yeah, it really went up quick.
Yeah. Well, they're not going to build it well, they're going to build it for the people that bring in the money. And I'm an endocrinologist.
Yeah.
It's not endocrine and rheumatology that are bringing in the money there.
No, we're not going to get our own buildings. I'm just happy I'm still in the hospital.
Yeah.
Been farmed out somewhere.
That's funny. That's great. Um, all right, so I'm gonna go ahead and share these slides, and then yeah, so a minute or two after the hour, I'll pull the slides down and we'll do the introduction and get started. Okay?
Perfect. All right.
Wonderful. Thank you.
Thanks.
Good morning, Dr. Sammaritano. This is Vivian Sue. How are you?
Sorry. Hi. Nice to see you. I'm well. How are
Same
you?
here. I'm very good. I'm just having trouble logging in on my computer, so I'm
Oh,
logged in on my cell phone now as I'm trying to log in on my computer. But welcome.
thank you. Thank you for inviting me.
Oh, it's my pleasure. I'm looking forward to hearing your talk. Um,
Well, I'm happy to know I wasn't the only one who had trouble logging in. And
yeah.
I had the good advice from Kirsten to start trying at 7:30.
Oh, yeah. Well, I guess I'm at fault there because I
No,
tried
no,
about 5 minutes ago. And
but you just never know.
anyway, I'm looking to see. If my name is, oh, it's here. I see it here. Let me just rename myself and then I'll introduce you. I see that people are still coming on, so I'm going to give just a couple more minutes.
Okay.
Vivian, I think people will still be coming in. I think to
More
give
than a
Dr.
couple minutes,
Samaritano
right?
some
Okay.
time.
Hi, David. How are you?
Hello, good morning. Yeah. Good morning, everybody. Welcome to the Department of Medicine Grand Rounds. The CME code for today is 31634. To introduce our speaker today, Dr. Vivian Sue, who's the chief of our Division of Rheumatology.
Well, good morning, everybody. Thank you for coming to Grand Rounds. And have the pleasure of introducing Dr. Lisa Sammaritano, who will review the 2025 treatment guidelines for lupus. So Dr. Sammaritano went to college at UPenn and then got a medical degree at Weill Cornell Medical School, and then stayed on for residency and fellowship, and then faculty. And she rose through the ranks to her current title of Professor of Clinical Medicine in 2020. And she also holds privileges at MSK. She has basically, I know that she's taught almost every year at the American College of Rheumatology meetings. I enjoy listening to her lectures on rheumatic diseases and pregnancy. But she's also taught us about lupus and how to best manage that, the antiphospholipid antibody syndrome, pregnancy, and the rheumatic diseases. She's traveled all over and taught all over the world, not just locally. She's written 70 manuscripts, 37 reviews, book chapters, and published, and just published, she's actually led the task force in the guidelines, developing guidelines for the 2025 management of lupus, which she'll present today. And she's currently also revising the 2020 guidelines for reproductive, for the pregnant patient with rheumatic disease. She's published on the antiphospholipid antibody syndrome. In particular, she has an interest on a protein called annexin 5 or annexin V. She, among other tasks that she has to do, she also supervises the ACL assays, the anticardiolipin assays at HSS. And she's also working on atherosclerosis and lupus. She's done key clinical trials in lupus and the antiphospholipid antibody syndrome in the rheumatic diseases. And all along, she's taught us about the importance of shared decision making and compassionate care. So, Dr. Sammaritano, it's yours.
Thank you. Thank you so much. That was a lovely introduction. I appreciate it. I am going to focus today, obviously, on lupus, but I do want to review the basics very quickly, just because, as internists, we don't necessarily see lupus all that frequently. And then I will touch on comorbidities that are very important to rheumatologists and internists caring for patients with lupus. And then I'll finish with going over the treatment guidelines we actually developed two separate guidelines, both of which were published in 2025, one for lupus nephritis and one for non-renal lupus. Our learning objectives, I mean, the basic point in terms of these guidelines are these. The first is that we have become more aggressive with our treatment for lupus nephritis, so that we are now recommending what we call triple therapy, which is a combination of glucocorticoid and two immunosuppressive agents. And then secondly, for general lupus treatment, we are advocating for more universal use of hydroxychloroquine, strictly limiting glucocorticoid exposure, which is a real pivot in rheumatology over these past, say, 10 years. And along with that, initiating immunosuppressive therapy earlier to allow a reduction in glucocorticoids, and overall to reduce morbidity and mortality both from lupus and from steroid. So very briefly, systemic lupus. It is a multi-system autoimmune disease, and it is sort of the classic multi-system disease. The range of organ involvement is very wide. There are many autoantibodies, and the spectrum of clinical disease severity is also broad. So we have patients who have a little arthritis and rash, and then we have those patients who present and go right to the ICU with their kidney failure, thrombocytopenia, and CNS lupus. So symptoms do vary greatly between patients, and diagnosis is based on history, and then physical exam, routine labs, and of course, autoantibodies and complement. And just again, briefly, 4 to 250 per 100,000 worldwide in terms of diagnoses, which has increased, probably in part due to greater awareness and better testing. The female to male ratio is really skewed 9-1 during the reproductive years. Most common age of onset is the reproductive years, 15 to 25, although children and older people can also develop lupus. It is more common in non-whites, African Americans, Asians, Hispanic Americans. And there's an estimated 500,000 patients in the US, most of whom are female. The prognosis is quite variable, as I sort of alluded to earlier. Overall, 10-year survival is greater than 90%, and that is a dramatic improvement from years ago. And the worst prognosis organ systems are CNS, renal, heart, and pulmonary. What about mortality? Well, there actually have been a lot of studies looking at this to try and identify what factors are most important or predictive. And this multi-site SLE cohort, this was published in 2006, showed that the overall standardized mortality ratio for patients with lupus is 2.4 and saw differences in cause of death. So early disease was more often due to active disease itself or infection. Late death really related to a lot of these comorbidities I'll talk to you about, as well as chronic disease, including end-stage kidney disease. The SMR was highest for females, younger ages, lupus duration less than 1 year, and African American race. This is the only slide on pathophysiology I will show you, and I'm showing it not because that's the point of this talk, but just to emphasize that there's really been a tremendous amount of research in recent years, and that research has really identified not only the importance of B and T cell activation, but also interferon pathways, immune complexes with nets and defective clearance of autoantigens, the microbiome, and of course the impact of environmental factors, the most common of which are infection and UV. And these are the lupus classification criteria. I show this to point out that these really have changed over the years. In 1971, the American Rheumatism Association, now the ACR, published these criteria. And, we are very used to, myself included, still thinking 4 of 11 criteria, because that's what we have learned in medical school. But back in 71, they did not have ANA tests yet. So these have evolved over the years, including the ANA, getting rid of LE cells, the serologic test for syphilis, which has evolved to presence of antiphospholipid antibodies. And these are the current 2019 classification criteria, which, as with all of our current criteria, are somehow more complicated, but better. So for these criteria, you must have an ANA to be considered for diagnosis. So according to these classification criteria, and I'll come back to the difference for diagnostic criteria, but for these, you must have an ANA. It is a weighted scale so that more severe or more lupus specific things have higher weight. And it added some other symptoms that were not there previously. And if you have a positive ANA, if you have one clinical and one immunologic domain positive and a score of 10 or more, you classify as having SLE. And they have studied these and compared them to previous criteria. They are more sensitive and more specific. However, they are classification criteria, not diagnostic criteria. And we don't have diagnostic criteria for SLE. So we use these clinically, but really they're meant to be used for study inclusion. Because if you're doing a treatment trial, it's challenging enough with the multiple systems involved to assess response in SLE. So you really want to be quite sure that the patients you are entering into the trial meet everyone's idea of what SLE is. So for clinical diagnosis, we use them for guidance, but there may be patients with less common manifestations of lupus who still clearly have lupus. So characteristic autoantibodies, ANAs, are really almost universally present, although the titer can be variable, but they're not specific. They're present in many other autoimmune diseases, present in the normal population, often transiently, and the likelihood of a positive ANA is greater in children because of their constant infections, and in the elderly because of changes in the immune system as we get older. So they can be infection-induced, they can be drug-induced. DNA antibodies, specifically double-stranded DNA antibodies, are more specific, although today's assays that we get when we order double-stranded DNA antibody from commercial labs, they are less specific. So we often will see someone referred for a positive double-stranded DNA that is borderline with a negative ANA. And the issue is that ELISA tests can have non-specific binding, so these are likely false negatives. When that comes up, we check a Crithidia assay, which is more specific, and that can be helpful. SM antibodies are present in a third of patients but are specific. And antiphospholipid antibodies are not specific. Obviously, patients can have these alone or can have them in the setting of other autoimmune diseases, but they are present in a third of lupus patients. And these are the three assays that are considered the classic assays for antiphospholipid antibody. So we have done away with the serologic false positive test for syphilis, although we still do see it sometimes. And sometimes that is the way a person is diagnosed with presence of antiphospholipid antibodies. We look at complement levels and markers of inflammation as well. This is an overview to emphasize for you what I started out saying, which is that lupus really can affect almost any part of the body. In general, the most common organ systems affected are the joints and the skin. And this is a quick run through of manifestations. Constitutional symptoms are really common but non-specific. Arthritis or arthralgia, really common. There may be swelling and it may look like the patient has rheumatoid arthritis, but usually this is non-erosive. They can have debilitating arthritis, but once treated, their hands or other joints will look normal, with the exception of what we call Jacquard's arthropathy, which is a condition that is seen in lupus where there's a reducible deformity, and it's not due to inflammation in the joint per se, it's inflammation in the tendons. And the tendons become lax, and because of that, the joints lose their normal contour. Cutaneous manifestations, you can have acute, subacute, and chronic lupus. And chronic lupus includes discoid lupus, and it's a lot of patients, usually with photosensitivity. These are acute cutaneous lupus rashes, which includes the butterfly rash. The nasolabial folds are usually spared. This is discoid lupus rash, a kind of chronic lupus. There are other manifestations. Discoid, unlike acute lupus rashes, can occur on its own. So these patients may only have discoid lupus. They may be followed by dermatology. We don't necessarily see them, but this is the rash that causes scarring. And if it occurs on the scalp, it causes hair loss. Subacute cutaneous lupus has this characteristic sort of serpiginous pattern. And then, of course, mucosal ulcers, another mucocutaneous manifestation. Kidney involvement is present in about 50% of patients, ranging from proteinuria with red blood cell cast to hypertension, edema, anasarca, and renal failure. And so prognosis and treatment depends very much on renal biopsy. Hematologic manifestations are also common. Anemia is usually anemia of chronic disease, but may be hemolytic or from associated renal disease. Thrombocytopenia is common, and leukopenia is common, usually lymphopenia, as opposed to neutropenia, and usually not of clinical significance. Cardiac and pulmonary are also fairly common, pleuritis and or pericarditis. So while these may be debilitating in terms of symptoms, the more severe manifestations are when you have pneumonitis, pulmonary hemorrhage, development of pulmonary hypertension, myocarditis, heart valve abnormalities, and of course, accelerated atherosclerosis, which is sort of one of those comorbidities I'll get to. There may be vasculitis, which is not common, but common is Raynaud's syndrome, as seen here with vasospasm. Neuropsychiatric lupus is a very confusing area. I put the NPSLE case definitions up here just to show you that people have looked at this, have decided that these 19 different syndromes may all be seen in lupus. They're not all part of classification criteria, but suffice it to say that lupus CNS involvement can be quite variable and range from mild cognitive dysfunction to debilitating confusional state, seizure, stroke, etc. So these are some of the comorbidities. Premature atherosclerosis is unfortunately really common. And I can tell you from personal experience, years ago, I admitted a patient with lupus to the hospital with nausea and vomiting, 30 years old. Turned out on her admission EKG, she was having an acute MI. She had been on high dose steroid for many years because she presented with childhood lupus. So I'm sure that was a part of what precipitated the development of the atherosclerosis. But epidemiologic associations going all the way back to early years did show what we now recognize as this bimodal pattern of mortality. And I hinted at it earlier when I showed you causes of death. So basically, early deaths are often due to disease and infection. However, late in the course of disease, a lot of atherosclerotic cardiac disease. And cohort studies also confirm this bimodal pattern. So 17% of early deaths due to cardiovascular, 30% of later deaths. And in this cohort study, the mean age at first coronary event, 48. Another study compared the age-specific incidence rates of MI and angina in women with healthy women in the Framingham offspring study and showed that women with lupus from 35 to 44, I mean, it's a young age, right? So not surprisingly, they have more than 50 times the likelihood of having an MI. 2/3 of the first cardiac events following diagnosis of lupus were in women less than 55. They also have increased risks of other cerebrovascular disease and peripheral vascular disease. And why is this? Well, briefly, we think it is a combination of increase in traditional risk factors, because that happens with our patients with lupus, but also probably ongoing chronic inflammation. And I think that nowadays, this is not such a surprise as we learn more and more about the pathogenesis of development of atherosclerosis and cardiovascular disease and the importance of inflammation in that. So large studies have confirmed traditional risk factors are important. A lot of our patients have hypertension. A lot have elevated cholesterol, in part related to their therapy. But traditional risk factors fail to fully account for this accelerated atherosclerosis. And as you can see over here, when you take the Framingham risk factors into account, you can see still quite an increase in risk in patients with lupus when controlling for those risk factors. So we do think disease-related factors are important. This study from Mary Roman and Jane Salmon at HSS and New York Hospital showed that over a third of patients with lupus had carotid plaque versus lower proportion of controls. And the independent predictors related to disease, so within the lupus group, disease duration, amount of damage, and this was done years ago. So our big drug at the time was cyclophosphamide, less likelihood of having been treated with cyclophosphamide, all of which suggests more uncontrolled disease activity leads to a higher chance. So although, and this is just, I put this because this is a great review article on cardiovascular disease and damage in lupus and the potential pathophysiology. But basically, we don't have a lot of lupus-specific studies to guide us in treatment. So we treat traditional risk factors aggressively and treat disease aggressively as best we can. So here are a couple of other comorbidities that I wanted to bring up because, again, lots of low overlap with general internal medicine care. Osteoporosis and fractures, more common in women with SLE. And so this initial study that I show here was a cohort study of women with lupus, age matched controls. It was self-reported fractures, but still 12.3% of lupus patients reported having had a fracture. It was a 5-fold increase over those reported by controls, and 1/2 of those happened before menopause. The associated variables in this study, obviously age, but also longer disease duration, longer steroid duration, less use of oral contraceptives, because remember, for many years, our lupus patients were told never to take oral contraceptives, and then obviously menopause. And this more recent meta-analysis basically just confirms what the earlier studies showed. 31 different studies, and basically the odds ratio for diagnosis of osteoporosis in SLE is 2.03. And the same factors seem to be important. Age, menopause, of course, but disease duration, cumulative steroid dose, length of steroid dose, and amount of lupus-related damage as measured by this index we use, the SLIC index. I do want to touch briefly on reproductive health issues as a sort of comorbidity-related topic. And this is a topic that is really near and dear to my heart because I worked on these ACR guidelines for management of reproductive health in our patients, in all rheumatology patients. Guiding principles, important to use safe and effective contraception because unplanned pregnancy is bad in lupus. And pre-pregnancy counseling when you can, of course, that's an ideal state, but encourage conception during a period of disease quiescence and when women are on medications that are safe or compatible with pregnancy. just a couple more slides on this. Contraception, it is a big topic in lupus, and that's largely because a third of the lupus patients have antiphospholipid antibodies, and that makes a difference in terms of risk of thrombosis if one is on estrogen-containing contraception. So the main message in terms of contraception is that we actually recommended in our guideline long-acting reversible contraceptives, so-called LARC. They are the most effective, and they're recommended first line for all women with lupus, regardless of their age, parity, presence of immunosuppressive medications, or APL status. They do not contain estrogen. The more common one is an IUD, whether a progesterone containing one or a copper IUD. The other version is a subdermal implant, also progesterone containing. Combined hormonal contraception, that is, estrogen and progestin, is contraindicated in the presence of a positive antiphospholipid antibody in patients with lupus or any patients. But it's not contraindicated in antiphospholipid antibody negative and clinically stable lupus. And that was shown in two studies, one of which I was involved in, the Selena study, published in 2005. But another study from Mexico confirmed this. They were published side by side, that for patients with quiet disease and no APL, these lupus patients can take combined hormonal contraception, usual pills, if they choose, if they decide they don't want an IUD or for some reason can't have that. Progestin-only contraception is useful for patients who do have positive APL. And then just a note, should you be asked, over-the-counter emergency contraception, which is non-prescription and is an oral form of a progestin, that is safe for all SLE patients to take, whether or not they have APL, thrombophilia, cardiovascular disease. In terms of pregnancy, maternal mortality has really improved dramatically, and you can see the difference from early 2000s, 0.3% down to 0.025% in the mid 2000 teens. However, pregnancy complications really haven't improved as much as we think they should have. So as you can see from this study, preeclampsia really not significantly changed and still higher than in the general population. And this study from Vanderbilt, looking at their EPIC database, showed that lupus deliveries compared to controls still significantly increased risk of preterm delivery and preeclampsia. And when they looked at it longitudinally, as the previous study did, these things were not getting better over time. Like, this average isn't that it started at 16 and was down to 2. They really were the same over this period of time. So we have a ways to go in terms of improving our pregnancy outcomes. But we do know this: inactive disease is good, and we encourage people to have that for 6 months before they conceive. It lowers the risk of lupus flare and it improves pregnancy outcomes. We try to identify and manage risk factors as best we can. The 3 big risk factors for lupus patients: presence of antiphospholipid antibody, renal insufficiency, or even history of lupus nephritis with normal renal function, and then flare. And then lastly, there is a risk of neonatal lupus with the presence of anti-Rho antibodies, and that's present in a third of our patients. Most of those manifestations, like rash and cytopenias, are reversible. The one irreversible one is congenital heart block. That risk is 2%, but is lowered to about 1% if we treat with hydroxychloroquine. And there is a lot of research right now being done, a big study, national study called Stop Block, trying to identify the best way of monitoring and the best treatment for pregnant women with anti-Rho antibodies to prevent development of congenital heart block, complete heart block. The last pregnancy point I will make is that EULAR, which is the European equivalent of the American College of Rheumatology, just published updated pregnancy guidelines, and they advocate for more permissive use of biologic immunosuppressives in pregnancy, including belimumab and rituximab, which gives us more to use for flare. What about cancer risk? Well, it is increased in patients with lupus, as it is in many patients with chronic autoimmune disorders. I highlight here, though, the hematology related cancers because those are by far the most common. In addition, cervical dysplasia is increased in patients with lupus. Unclear whether this is related to lupus itself or the often common use of immunosuppressive therapy. But this meta-analysis, showed an odds ratio of over 4. We recommend, of course, HPV vaccine, and this is the case where we might recommend it even for women who are older than 26 or whatever, and increased surveillance because their risk is higher. So, what are our standard treatments for lupus? Well, treatment is not based on diagnosis per se. It's based on the location of inflammation. Is it the skin or the kidney? How severe is the inflammation? Is it mild? Is it life-threatening? NSAIDs, of course, we use for arthralgias or mild serositis. Hydroxychloroquine, I will circle back to, but the reason it is recommended now universally is that many studies show it doesn't just help certain symptoms. It does help especially joints and skin, but overall, even when used with other immunosuppressives, it reduces flare risk, development of organ damage, thrombosis, and it increases survival. Corticosteroid is used for the whole spectrum of inflammation at varying dosages. Again, a big emphasis now on trying to limit use to when it's most needed. Conventional immunosuppressive agents provide a steroid-sparing effect for severe disease. And these are listed here. The newest one, well, I will say azathioprine, methotrexate, cyclophosphamide, they've been around forever, meaning since I was a fellow. Mycophenolate is a newer addition to our immunosuppressive agents and has really taken over in terms of sort of first line use for most manifestations. Voclosporin is a calcineurin inhibitor that was recently FDA approved for addition to baseline or standard therapy for lupus nephritis. And now we have biologic agents. So belimumab was initially approved for general lupus, more recently approved in combination therapy for nephritis, and anifrolumab, which blocks interferon, now appreciated as an important pathway in lupus, that is recently approved for non-renal lupus, and it's especially good for lupus rashes. Rituximab is used off-label, and obinutuzumab, another anti-CD20 agent that gives a deeper level of B-cell inhibition, was just approved this past year for lupus nephritis. So you will see that our lupus nephritis guidelines that I'm coming to next do not include obinutuzumab because these data were not available when we were formulating our recommendations. But it is likely that with our next revision, which will have to be soon, that we may include obinutuzumab as a third agent in our so-called triple therapy. Okay, so treatment of lupus nephritis. We didn't have a standard of care until 1992, and that is when the NIH protocol was published, IV cyclophosphamide monthly for 6 months, followed by quarterly for 2 years. And that worked well, and it worked better than steroid alone, which was what we were using before that. However, it really carries a lot of risk of morbidity. In 2005, it became clear from studies done then that mycophenolate mofetil, which we borrowed from our nephrology colleagues who were using it for transplant patients, was really equivalent with fewer side effects. So although they did not pursue FDA approval for this, it really is standard of care now for initial induction therapy. After that, studies were done to compare azathioprine, our previous maintenance therapy, to mycophenolate. And these studies showed that mycophenolate did a better job of preventing recurrence of lupus nephritis. So as of 2012, which is the last time the ACR published guidelines for treatment, it was, of course, glucocorticoid, induction therapy with either cyclophosphamide or mycophenolate, and maintenance therapy, mycophenolate preferred to azathioprine. The Euro Lupus protocol is a variation of IV cyclophosphamide that gives lower, more frequent doses. It is shown to be as effective with less of a cumulative dose. Second-line agents have been rituximab and tacrolimus. So now we have published these new treatment recommendations. Why now? Well, we published the old ones a long time ago, and there's been a much wider adoption of meds off-label, as I just showed you, new FDA approvals both for general lupus and lupus nephritis. So for lupus nephritis, belimumab, voclosporin, and obinutuzumab are now FDA approved as additions to standard therapy, previous standard therapy, on the basis of really well done randomized controlled trials that showed the benefit of adding a third immunosuppressive agent to standard therapy without an increase in, infections or other adverse events. And I think so it's all of this plus our ever increasing appreciation of the risks of chronic glucocorticoid related to both dose and duration. So how do we do this? Well, we use a method called grade methodology that involves a number of teams that together make up the guideline team as a whole. There is a core team that decides on PICO questions, which are the most important clinical questions. That is passed on to a literature review team who does a systematic literature review and then compiles and grades the evidence. And that, along with results from patient panel discussion, is sent to the voting panel where they discuss and vote on specific recommendations that incorporate the evidence, the patient's values and preferences, as well as their own clinical expertise. So recommendations are not just based on the evidence. If that were the case, we would have far fewer recommendations because honestly, the level of evidence is not what we would hope for ideally. It is better for lupus nephritis studies because of these studies I mentioned earlier, not so good for general lupus. This is just a schematic to show you the grade process. PICO questions are questions that ask, what is the benefit of adding this compared to either control or not adding this in terms of a particular outcome. So, and you look, of course, at the importance of the outcome. This is what the evidence profile will look like. It gets rated. Don't ask me how, but it's included here. The methodologists who are doing this can upgrade it or downgrade it depending on specifics of the studies themselves. This then is sent to the voting panel. The patient panel has a separate full day discussion, and then two patients are included as members of the voting panel to bring the patient perspective. Recommendations are voted on or rewritten and voted upon, and then we end up with this guideline. And we end up with strong recommendations and conditional recommendations. In terms of lupus nephritis, these are obvious goals that we want to preserve kidney function, minimize morbidity, mortality. emphasize collaborative care, utilize shared decision-making, aim to reduce healthcare disparities, and we tried to incorporate pediatric and geriatric specific recommendations, recognizing that lupus affects patients of all ages. So we ended up with 28 graded recommendations. 7 were strong, 21 were conditional. What does that mean? They really are not the same. And it's important when reading a guideline such as this to appreciate that. Strong recommendations basically mean everybody should follow them. The evidence is strong. The voting panel feels that this applies to almost all patients, and the patients feel that way too. Conditional recommendations represent this is our best recommendation based on not perhaps optimal evidence, understanding that there are wide clinical variations in patients, both in terms of clinical characteristics and their views on these things. So conditional recommendations mean bring this up with your patient, suggest it, and then discuss it based on the evidence, based on their particular views, their particular clinical situation. It might not be right for them, but it is likely that it could be, and it should be considered. Ungraded good practice statements are common sense statements. And then these apply to all patients, regardless of age, race, ethnicity, other variables. We didn't make specific recommendations based on race or ethnicity because those are so confounded by socioeconomic factors. And these are obvious, caveats. I will point out we did not recommend a particular calcineurin inhibitor, such as voclosporin, which is the FDA-approved one, because there really are not studies comparing different calcineurin inhibitors. And from our clinical practice, we are well aware that there may be limitations in accessibility to these newly approved agents, where an older agent may well be effective and available. Okay, so how do we think about lupus nephritis in patients with lupus? Well, we need to screen regularly because this is the kind of thing that can develop in the absence of other clinical symptoms. Easy when someone comes in with arthritis, malar rash, fever to say, oh, let me get a urine and make sure there's no kidney involvement. But when a patient comes in and says, I feel great, you still have to get the urine because that is the best, earliest way to check for proteinuria. And there are many patients with lupus who develop nephritis in the absence of involvement of other organ systems. I had a patient who ran the marathon and came in to see me afterwards. Not just proteinuria, elevated creatinine. I mean, she had had a progression of lupus nephritis since her previous visit that she was certainly unaware of. If you suspect it, you should do a kidney biopsy promptly. You should treat promptly with steroid while awaiting results. Don't wait 2 weeks for the final, report to come back. Kidney biopsy for unexplained proteinuria or impaired kidney function, we tend to use 500 milligrams as a cutoff, but sometimes it may be lower. Or, of course, if someone has a history and you suspect a flare. Hydroxychloroquine is recommended for all patients because not only does it have all of those benefits I showed you in an earlier slide, it has actually specifically been shown to reduce risk of lupus kidney flare in patients who are taking it. And then we do recommend RAS inhibition for all patients with elevated proteinuria. So let's go through the actual treatment recommendations. Glucocorticoid therapy, I've harped on to emphasize that we sort of want to hit them hard early and then pull back because that leads to less of a cumulative glucocorticoid dose, and that translates to less morbidity over the years. So our recommendation here was to give a pulse therapy in patients with newly diagnosed or flare of lupus nephritis. And we left it quite open in terms of how aggressive to be with the pulse. because clinical situations vary, and then follow it with oral prednisone, but don't start at a milligram per kilogram per day, which was often the case in the past. Start at less than or equal to 0.5 milligrams per kilogram per day with a maximum dose of 40 and taper it to less than or equal to 5 milligrams per day by 6 months. It is amazing how many patients will linger on steroid if you don't pay attention
Because you
to
had
the
said that
dose.
then they didn't pay.
Correct.
Uh,
So now it's double.
So what?
If if you don't pay attention to the dose, and the fact that they're still on it. And this was based on, a number of factors, but an important one was a recently published systematic review and meta-analysis that looked specifically at the use of steroid in lupus nephritis and found that pulse steroid, this regimen that I've just described, sort of maximized complete renal response while minimizing toxicity, which was primarily infection related. In addition, our patient participants strongly emphasize their preference for minimizing steroid. This is our overall treatment of lupus nephritis figure. And we separated it into proliferative lupus nephritis, 3 and 4, whether or not 5 was present, versus pure class 5 or membranous. And that's because they are different. All patients get hydroxychloroquine and a RAS inhibitor, assuming they have proteinuria. And I'll get to the details in a second. But just to give you the definition of triple therapy, it is addition of a second immunosuppressive to glucocorticoid therapy and the original long-standing standard immunosuppressive treatment with either MPAA, which means mycophenolate mofetil or mycophenolic acid, or cyclophosphamide. And that addition can be belimumab or a calcineurin inhibitor. As I mentioned to you, likely in the future, obinutuzumab will be added, and it's already being used clinically with the recent FDA approval. Okay, so for proliferative nephritis, we prefer mycophenolate to cyclophosphamide because of side effects, but either can be used. And then we tried to give guidance in terms of which patients might do better with which added agent. So belimumab is recommended if someone has a lot of extrarenal manifestations, because we know belimumab works well for non-renal lupus. Or if they have a low creatinine clearance where you cannot give them a CNI, or significant hypertension where there is a risk of worsening hypertension. Mycophenolate with a CNI is preferred for those with significant proteinuria because it has that added effect of reducing proteinuria. If using cyclophosphamide, we recommend this regimen I mentioned earlier. It's a lower dose for a shorter period of time. And this has been studied with belimumab, not studied with CNIs, although it's not recommended simply because there's no data, but it doesn't mean that it can't be used if seems appropriate. And why are we pushing this? There is or has been a push to just start with standard therapy and then reassess them after some months and see, well, do they need something more? And maybe that would be better because then they're not exposed to as many agents and as much immunosuppression. But the randomized controlled trials that I'll show you in a second that looked at belimumab, the BLISS trial, and Aurora, the voclosporin trial, showed that really when you start with triple therapy, you have better outcomes than when you start with dual therapy. And that really guided the voting panel discussion along with these other factors. And this is, I think, a very telling figure. So this is estimated nephron loss, and the nephrologists out there know this better than I do, of course. So excuse me for showing you something that you know. But with a single episode of lupus nephritis, this is the path that the creatinine clearance or GFR will take over time because there is, as you see here, gradual loss of nephrons and podocytes just with aging, and we know that. So if you don't control that first episode of lupus nephritis promptly, this is the path you will follow. So we really feel that we can't wait to see if they don't respond. I do want to point out that one of the things, I think it was on the slide, I didn't mention it, but one of the challenges of these guidelines is that we included a lot of people who did these randomized controlled trials that I mentioned to you, because the lupus nephritis experts are the ones we want on our voting panel, but they tend to be the people doing the trials. So we actually did a sensitivity analysis excluding voting panel members who had a relevant conflict of interest for this recommendation. And it did not, excuse me, result in a change in direction or strength. And, ACR guidelines, we have to have a majority of non-conflicted members on each team. These are the trials. I'm just going to briefly show you. Yes, the renal response was better with adding belimumab in the BLISS trial and adding voclosporin in the Aurora 1 trial. And you can see, and adverse event profiles were not different. For class 5, we recommend mycophenolate with a CNI, again, because of the stabilizing effects of the CNI. And then finally, total duration of therapy, 3 to 5 years. That is because people can have even a complete renal response, which is based on GFR and proteinuria, but still have evidence of immunologic activity on biopsy. And patients can have ongoing proteinuria from damage, but not have activity. So this was our way of trying to not treat someone forever, but treat them long enough that the histologic immunologic activity would be resolved. We, of course, recommend transplant. We recommend proceeding to transplant without requiring complete clinical or serologic remission, provided there's no other major organ involvement. And that's because the studies show that it does not make a big difference. And for years, lupus patients were denied transplants because their complements were low. So we do not feel that that should be a barrier. In addition, we really push for preemptive transplant when appropriate because it has better outcomes, yet lupus patients are much less likely to have a preemptive transplant. Okay, I have a few minutes left. I'm going to quickly go over non-renal lupus. And this is from the 1999 guidelines. And I will, you can look at it, but some patients with severe disease respond over the short term and long term with glucocorticoids alone, or, it was very descriptive. And they had really no strong evidence. So this was almost entirely expert opinion. And here's what was suggested for severe disease. You'll see chlorambucil, nitrogen mustard. That was not available or used when I was a fellow. So, and these are the guiding principles, really the same as with lupus nephritis. We want to control activity, prevent morbidity and mortality, and treatment toxicity. And we aim for lupus remission or what's called low lupus disease activity. And basically, that is acknowledging that not everybody will reach remission. Some patients will require a low dose of prednisone, but still, that low lupus disease activity is much preferable than uncontrolled lupus. This had 36 graded recommendations. Only 3 of them were strong, 8%. Most were conditional. What does that tell us? Oh, we really did not have a lot of strong evidence. And there was a lot of discussion and a lot of clinical expertise and patient input. Same as with lupus nephritis. And I will point out, because of the randomized clinical trials with lupus nephritis, we had more strong recommendations, but in here, only 3. Um, we recommend monitoring disease activity, and if you can, to use one of the instruments that are widely accepted. If it's just a PGA, that's okay. Disease damage should be checked yearly. Again, that can sometimes help to identify vulnerabilities, or it might prompt change in therapy, or at the very least, guide prognosis discussion. And this is the instrument that we use. Comorbidities and risk management. I just wanted to show you this table of which I'm very proud, because we didn't want our rheumatologists to forget about these important things that impact our patients. And this is the kind of stuff that in a patient without lupus will be handled by the internist, but we need to think about it too and work with the internist to make sure we don't forget any of these things. So it talks about, screening for underlying hepatitis or TB with medication use. It talks about vaccinations. It talks about screening for cardiovascular disease, osteoporosis, or other joint damage. So these are not formal recommendations, but the goal is to sort of put together generally accepted recommendations with their references, um, as a reminder to incorporate this into general lupus care. It can't just be about giving them medicine for the nephritis. And then, guidance and treatment goals. Well, I already told you, we really want to control disease to the greatest extent that we can. We want to use glucocorticoids promptly, but for the shortest period of time and at the lowest dose that's necessary. And that usually means initiating immunosuppressive therapy, just as with nephritis. These are our steroid recommendations. Use a pulse if there's a severe flare. Um, Try to taper to less than 5 milligrams per day of prednisone if patients are stable. Try to, if they are stable on that, discontinue the prednisone. And if you're not able to, consider initiating or escalating immunosuppressive therapy. These are just a couple of studies that support these recommendations. So this study was new lupus patients who were starting on steroid, and the goal was to try to taper them to less than 5 milligrams. They found in the treatment group, the taper group, there was no difference in relapse rates. Every month on prednisone less than 5 a day yielded less damage long term, but never tapering to less than 5 milligrams a day, obviously, as one would expect, gave more glucocorticoid related damage. And they were able to taper to this dose in nearly half of newly diagnosed patients. And then why try to taper to off? Well, this was a systematic review and meta-analysis to see whether or not that was possible in lupus. And it is more complicated. And, of course, this is a conditional recommendation, but some patients may be able to taper off. You need to try, if appropriate, but very much a discussion with the patient. It is hard to tell a patient on 3 milligrams of prednisone who feels great that they should start mycophenolate, right? So there's a balance, and it's very much patient dependent. However, this meta-analysis showed that while the risk for overall flare did go up if you tapered off, the risk for major flare was not increased. So you can see, even though it looks like that would be increased, it's not statistically significant. It's a thought, it's a goal. It may not, and certainly will not, be appropriate for every patient. I will just mention, universal hydroxychloroquine, continue indefinitely, at least at this point in time. Aim for an average daily dose of less than or equal to 5 milligram per kilogram to minimize retinal toxicity. You may need to use a higher dose. Of course, you need to have yearly monitoring. And we can check hydroxychloroquine levels, and there's a ever-growing literature looking at the association of level with risk of flare, and it may be that that guides treatment in the future, but not yet. As with renal disease, we recommend immunosuppressive therapy being tapered or discontinued after 3 to 5 years, if possible. And then for organ systems, this may seem obvious, but I can't tell you how many hours we discussed organ-specific treatments. And here's the reason why. There's almost no data on organ-specific manifestations in lupus other than nephritis. So we tried to put together organ system manifestations, but all of the specific recommendations are conditional. Consider this. The one strong recommendation is don't ignore it. If there is ongoing disease activity in any organ system that's refractory to whatever your initial therapy is, escalate that therapy rather than allowing ongoing organ inflammation. This is our figure that summarizes the organ-specific recommendations, starting, of course, with the universal hydroxychloroquine, glucocorticoids if necessary, but taper, pulse if there's a organ or life-threatening manifestation, and then escalate when refractory to initial treatment. So key takeaways for treatment now: hydroxychloroquine, limit exposure to glucocorticoid as best you can. It doesn't mean we don't use it. We try to use it more wisely than we have in the past. Don't be afraid of immunosuppressive therapies. They are better than prolonged high-dose glucocorticoid. Obviously, shared decision making is incredibly important in this disease with multiple manifestations. And there will be many factors, including very many patient-specific factors that will influence choice of therapy. I can tell you one key thing that came from the patient panel, besides we don't like taking steroids, is we don't like taking so many pills. You know, for voclosporin, for example, it's like 6 or 8 pills a day, and then mycophenolate can be 6 pills a day. And this pill burden was really hard for patients and could lead to non-adherence to therapy. And then, of course, this concept of triple therapy will not be right for every patient, but to consider to use it whenever possible or appropriate. So let me stop sharing. I have to figure out how to do that. Okay. I know, I think I'm just at time. I'm sorry. I meant to leave a few minutes, but I just felt like there was a lot to cover.
They're wonderful. Thank you. Vivian, I don't know if you wanted to start off.
Well, I'm seeing a question on the chat from Dr. Clark. She says that she commends the ACR for engaging patients every step. She wanted to know, how did we do this? How did you do this?
So this is a standard procedure that that we use for all ACR guidelines now, I think maybe since 2015. So they reach out to patients through, they have a lot of patient advocates who are who work with the ACR. They reach out to those and they ask for patients to volunteer. Then they send them a questionnaire so that we can understand what their lupus is. So obviously for lupus nephritis, they had to have had lupus nephritis. Then we choose, the patient panels were either 13 or 14 patients. Try to choose with a variety of age range and that kind of thing. And we do get a confirmatory statement from their rheumatologist acknowledging, you know, their diagnosis. And because sometimes patients may think they have lupus when they don't. I mean, we all see this. So we definitely make sure they have lupus. And then thankfully, you know, with the use of Zoom or Teams or whatever, we can have a patient panel meeting that is like this, a lot easier for people to participate in. When I did the reproductive health guideline, it was an in-person meeting in Atlanta where the ACR is based, as was the voting panel discussion. So this has made it a lot easier to have like important conversations without asking people to travel halfway across the country. So we had a lot of geographic variation too, just because we were able to.
Right, thanks.
Yeah,
Any other?
I was going to actually make the same comment that Jean did. The ACE, which is our National Endocrine Society, it does the same thing, incorporating patients into guidelines. I don't know which other um, which other organizations are doing it, but it is a great thing.
Mhm.
There's another
I have
question
a question.
about
Yes.
pulse steroid, 1,000 milligrams versus 500 for non-renal and non-CNS lupus. Do you recommend a lower dose?
I usually do, yes. We didn't want to limit people. It's so challenging to write these recommendations because no matter what you come up with, someone disagrees. On the voting panel, never mind, across the country. So, yes, but I do think that for non-renal lupus, most of us will use 250 or 500. Sometimes people will give 1,000 for one day. I think and sometimes they won't give a pulse. I can tell you that one of my colleague, NYU colleague, who was not involved in this, said, you don't have to give a pulse because you can give them dexamethasone for 3 days, and that should work just as well. And one of our voting panel physicians said the same thing because you know what? There are limitations in accessibility to getting a pulse for somebody. And I completely agree. So that is a conditional recommendation. Think about it, consider it, discuss it. But otherwise, sure, give them a high dose for a few days if you can't give them a pulse, or if they're not willing to do that. But then let's try and follow, this fairly rapid taper compared to tapers in the past.
Thank you. One last question from Dr. Maroon.
Yes, thank you for this excellent presentation. So, with the new recommendation and the focus on decreasing the steroid dose, we often use the SLEDAI scores in clinic, and SLEDAI scores do not incorporate the steroid usage. So, should we be moving toward another measure where we can look into the prednisone dosage that is used and the cumulative dosage to look for disease remission and low disease activity?
Yeah, I think that is a great point. And I can tell you that just to talk about nephritis for a second, our complete renal response definition in the guideline did not include steroid dose, but many do for just the reason that you're saying. So we're asking people to do two things in tandem when really maybe we should be putting them together, right? So we want you to have progressively lower and hopefully low baseline SLEDAI, but we also want you to be decreasing that steroid so that at the 6-month mark, it's 5 or less. So I think that ultimately maybe that is the way to do it, to incorporate it. It would be simpler, but we haven't done that yet.
I have one more question. For lupus nephritis patients who undergo transplant, kidney transplant, what is the risk of recurrence of lupus nephritis in these patients?
So the risk is very, very low. And we think it's because their transplant medications are essentially lupus nephritis medications. It is not impossible. It can happen. And certainly, and they can have non-renal flares. But overall, those patients tend to do well. And we treat them in conjunction with nephrology if they do have a non-renal flare. And I saw there was a comment asking about incorporation of biologics early. So I think that was the question. I will say one of our most animated discussions during the voting panel meeting was just about that point because we don't have comparative data looking at initiating a conventional immunosuppressive like Cellcept or mycophenolate compared to a biologic. So if you have a patient with ongoing lupus arthritis and they're on hydroxychloroquine and you can't lower the steroid without adding something, what agent should you add? Well, in this guideline, we actually ended up saying to start with a conventional, and often for arthritis, people do use methotrexate, not for other things, just for arthritis or maybe cutaneous. But with a low threshold to either change or escalate to a biologic. That's in contrast to dermatology specific recommendations, which said start whatever you want. And it was a compromise among a very diverse group of clinicians and patients. But I think as we have more data, because if you think about all of the trials that have looked, or to date, all of the good quality trials that have looked at biologics have added them to standard therapy in many cases. So it's very hard to know whether they are equivalent, whether one is better than the other. And that's a ongoing area of research. And I do think that's something that we will hopefully, refine and revise as more evidence is available.
Thank you so much, Dr. Sammaritano, for coming and talking to us.
Of
Dr.
course.
Sammaritano, sorry, I had a question, and people, we're way past the hour, so people feel free to sign off. But I had a question about your recommendations about contraception for women, and your discussion about, if I understood correctly, restricting or minimizing progesterone use in combined oral contraceptives. Is that correct?
No. And I'm sorry, I zipped through that and I usually make it a whole talk, but I wanted, so here are the contraceptive points that I hope to make. First is that for every patient, they really should, ideally, again, it's not necessarily what the patient wants, so you have to discuss. But if I could decide, they would have an IUD
Mhm.
or a subdermal implant. Progestin only, is the subdermal implant. Progestin is okay for everybody. You don't want them to have a huge dose of progestin. So, for example, and I didn't go into it again because of time, but DMPA, the injections, those we do not recommend for everybody because there is data suggesting that that can increase risk of thrombosis, and it also can increase risk of loss of bone density. But other progestins, all good.
Okay.
Combined contraceptives, just avoid them if a patient has active lupus because of the risk or concern of estrogen prompting a flare, or if they have antiphospholipid antibody or other, thrombosis risk factors because estrogen can trigger a thrombosis. And then the progestin over-the-counter pill is fine for everybody.
Great. All right. Yeah, I was going to follow up because the medroxyprogesterone, the DMPA, like you're mentioning, that has the associated with the excess risk of
Yes,
cardiovascular events and breast cancer, but micronized progesterone hasn't shown.
exactly.
Beautiful.
Yeah,
Thank you.
and I'm sorry, I should have clarified, but again, I was trying to not add yet one more slide or one more point, but it's an important point. So thank you.
Thank you very much.
Great. Okay, well,
Thank
thank you
you.
for having
Take
me. I
care. Have a
really
great
enjoyed
week.
it. Thanks.
Bye-bye.
Bye.